Now let's run through some important studies. Though there are tens of them, we will be going only to 3 or 4 of the important ones. Now the Australian study is a very important called the PREVENT study. That is antibiotic prophylaxis and recurrent urinary tract infection in children. And this PREVENT is prevention of recurrent urinary tract infection in children with vesico-ureteric reflex and normal urinary tract. Now, it's a well-powered placebo-controlled study done from birth to 18 years of age. The trimethoprim sulfamethoxazole was used to prevent recurrences in 1 or more febrile UTIs. There was a modest decrease in the new infections in the prophylaxis group. There was some effect, and 14 children had to be treated to prevent 1 case of urinary tract infection. And the problem was there was a recurrent infection by resistant organism. Therefore, the resistance increased. Therefore, that's what it showed. But what is most important, though there was a statistically significant difference, given the modest reduction in the clinical risk of urinary tract infection in the antibiotic group and the lower risk of renal damage, 5% occurring with a single infection, the magnitude of the benefit is likely to be small at best. But what they said concluded was that though there was some statistical significance, the clinical significance was not much. The other study we will consider is the Swedish reflex study. This is the only clinical trial to specifically evaluate children with higher grades of reflex, grade 3 and 4. The Swedish children 1 to 2 years of age, 63% girls with grade 3 or 4 vesico-ureteric reflex were assigned to antibiotic prophylaxis with trimethoprim, nitrofurantoin, or ceftriaxone, or endoscopic treatment, or no treatment or surveillance alone. Now, there was no significant difference between the group differences in outcome among boys, but girls assigned to surveillance had more recurrent infections. Therefore, the antibiotics as well as endoscopic treatment had benefit in girls but not in boys. And the girls also had fewer scars at 2-year follow-up. This study is often quoted to say that in grade 4 and 5 reflex, female children benefit from prophylaxis while boys do not do. But one of the criticism, and a very important criticism, is that this study was not powered well enough to arrive at this assumption. And children below 1 year were excluded because some of the patients with even grade 4 and grade 5 reflex below 1 year disappeared spontaneously. This study is often quoted to say that prophylactic antibiotic is effective in females with grade 4 and grade 5 vesico-ureteric reflex. There are many studies and many meta-analyses in this subject. One often quoted is a 2011 AAP meta-analysis, which reviewed data of 6 randomized clinical trials from 1,091 patients from age 2 to 24 months and found no statistically significant benefit of prophylaxis. There's a word of caution from some of the recent journals. This is a very important article published in 2018 in the Pediatric Nephrology Journal. And this states that though there are multiple RCTs and meta-analysis, an over-review demonstrate variable subpopulation and methodologies of these studies evaluated. The many confounding effects suggest caution on recommendations or guidelines based on these meta-analysis. Therefore, you can't follow a guideline which blindly follows a meta-analysis. This has come in a very reputed pediatric nephrology journal, and normally we give much importance to meta-analysis, and guidelines are based on that. Now, the most quoted study, the most important study is the report study, which is brought about published in the New England Journal of Medicine, and it is randomized intervention for children with vesico-ureteric reflex. This was a study which is considered the best in this field, and is a multicentric placebo-controlled trial of prophylactic trimethoprim sulfamethoxazole for children aged 2 months to 6 years with grade 1 to grade 4 reflux. Antimicrobial prophylaxis in children with vesicular reflux diagnosed of the first or secondary urinary tract infection was associated with halving of the risk of febrile or symptomatic recurrence. Therefore, there was a substantial benefit in when they gave trimethoprim sulfamethoxazole, and this is particularly effective when the first episode is a febrile UTI and those with bowel bladder disturbance. However, the rates of renal scarring at the outcome visit were low and were not reduced by prophylaxis. Though the infections came down, the renal scarring did not come down. But the number of children who had scars were very less. Now, this study is considered the best study so far done, but only one antibiotic, that is trimethoprim sulfamethoxazole, is used. Recurrences were definitely less in the antibiotic group, but the follow-up for scarring was only for 2 years and no significant difference was found out. A very small number of boys was enrolled. Surprisingly, only 9% of the patients were boys. This is something you find in VUR in the Western countries. You find it very more common in girls. But this has not been the impression in India, where boys are also affected as much as girls. Now, they say that prophylaxis is beneficial to a distinct population comprising of girls with a low-grade reflux and BBD. But the problem was there was an increasing incidence of resistance. Therefore, there is a double-edged weapon. It looks like a double-edged weapon. Though it is beneficial, especially for girls, in decreasing the recurrence, it has increased resistance and does not seem to be decreasing the scars, though the study was not powered to find it out. And the point to note is that though it was associated with with the statistically significant decrease, they found out that you required 5,840 doses to be given to prevent one UTI. Therefore, often it is asked, many pediatricians ask, the RIVER study, which is considered the best study, double-blind, placebo-controlled study, in which trimethoprim sulfamethoxazole has a definite benefit to the extent of halving the incidence. Why can't we give continuous antibiotic prophylaxis? But remember, who's going to take 5,840 doses before compliance will be a problem? Number two, it doesn't decrease the scars. Number three, it increases the resistance. Therefore, though the best known study in this field showed benefit, it is now, the jury is still out regarding continuous antibiotic prophylaxis in preventing urinary tract infection in children. Now, it's not all bad news regarding antibiotic resistance. There is a recent paper published in the Pediatrics in 2016, 4 years ago. Now, it states that although prophylaxis increases the risk of resistance to trimethoprim sulfamethoxazole in a subsequent UTI, the incidence of resistance appears to fall over time. That means if you wait for some time, the resistance disappears. And the resistance to the index case of UTI does not increase the risk of recurrent symptomatic UTI in these children. Therefore, it is not all that bad news. And this point, probably, when the incidence of resistance appears to fall over time, was known to pediatricians before. And this was the reason probably why they used to rotate the medicine, the antibiotic medicine, every 3 months, like giving cefalexin for the first 3 months, rotating it to trimethoprim sulfamethoxazole, and then to naldixic acid, etc. But this is no longer accepted. But even today, antibiotic resistance is one of the main reasons that is quoted as one of the reasons stated that we should not be giving antibiotic prophylaxis routinely. In a very recent article in Pediatric Nephrology in August 2018, which says primary vesicular reflex, what have we learned from the recently published randomized controlled trials, goes on to state that primary vesicular reflex does not lead to increased recurrence rate of UTI, a bombshell actually, especially in those with BUR grade 1 to 3. Recurrences in grade 4 and 5 seem to follow the same pattern, although the evidence is not conclusive. This is not how we look at it, but it goes on to say that grade 4 and grade 5 also doesn't lead on to recurrence UTI. These are recent publications in very reputed journals, mind you. And the BUR as a risk factor for acute pyelonephritis has not been confirmed, but the limited available evidence suggests that BUR does not predispose to acute pyelonephritis. Please note that this article has come in Pediatric Nephrology, and it is a summary of the evidence available, and it is be as late as 2018. Damage. And some of them go on to state that even if prophylaxis is effective, there is increasing doubt that the recurrent UTI in children with normal kidneys lead to long-term sequelae, even when such infections result in renal scarring. Therefore, to this extent, they say even if it results in renal scarring, there is increasing doubt that recurrent UTI can lead on to renal damage in normal kidneys. To add more credence to how the pendulum is swinging, an archives of art in an article which came in Archives of Disease of Childhood in this month, October 2020, states that long-term antibiotic prophylaxis to prevent urinary tract infection in newborn with antenatal ultrasound detection of urinary tract dilatation is now challenged. I don't know how much the neonatologists would agree with this. Studies show a low recurrence of urinary tract infection in patients with urinary collecting system dilatation who are not prescribed continuous antibiotic prophylaxis. Now, this is one standard practice in neonatology, that we do prescribe long-term antibiotics from newborn period in children who had an antenatal ultrasound which showed a dilated collecting system. But this is an isolated article, but it's a very well done study in a very reputed journal which came this month of the year. I reviewed most of the important articles which were published in the last 10 years, to drive home the fact that almost all of them have evidence against giving continuous antibiotic prophylaxis in UTI. I didn't find a single article which supported that. Now, I do that because I find, on the contrary, back in India, I find most of the pediatricians are tuned to giving continuous antibiotic prophylaxis even after the first urinary tract infection, let alone recurrent urinary tract infections. And I find also most of the webinars in which the leading lights of the pediatric nephrologist in IAP webinars advocate to give continuous antibiotic prophylaxis. Their argument in favor of is that we should tune our practice to the situations in which we practice, in the countries in which we practice. However, I find it very difficult to follow something for which there is no evidence. In fact, there can even be harm. Now, I have reviewed the whole literature. Now it is your own judgment. You can use your own judgment to decide whether you want to give or not give. This is a series of three videos, and the next video will be a synopsis of the guidelines, which have some reference to continuous antibiotic prophylaxis in UTI. And the last and the fifth video will give you what I feel should be the practice. I will summarize and tell you what I feel should be the practice.